So the biophysical profile, or the BPP, again, this is all done antepartum, so before delivery, before labor processing starts. So during the antepartum period, we complete this non-invasive assessment of the fetal well-being by completing an ultrasound and then scoring it against a standardized tool. So you can see that referred to in Chapter 26 in your text, Table 2. So we're going to look at that amniotic fluid volume, fetal breathing movement, looking at that lung expansion, overall fetal movement, fetal tone. So we're looking at that baby, that fetus, looking at it extend and return to flexion. So we'd be concerned for contractures or anything like that if we noted some abnormalities related to that. And a non-stress test for fetal heart rate variability. So if we notice any kind of low scoring, we're going to be noticing that we need to do some additional very close monitoring. So some additional monitoring. So how would we do that? Well, the biochemical assessment, there are different types, okay? And we're looking at chemical and biological determinants. How are we going to determine how well this baby is doing? We might do an amniocentesis, a percutaneous umbilical blood cord sampling, a chorionic villi sampling, or a maternal sampling in order to get these results. Okay, so let's say we did your ultrasound. There's some abnormalities on your ultrasound. The doctor calls you. You're all upset. You're very concerned. You're very worried. You don't know what's happening. Okay, so the doctor says through the nurse, we're going to have you come back into the office and we are going to complete an amniocentesis. So the amniocentesis, what this does is we're going to obtain some amniotic fluid, and then within that amniotic fluid we have free-floating fetal cells, and we're going to put those under a microscope, or we're going to send them off for testing. So amniocentesis, we're going to need a couple of things. We're going to need an ultrasound, which is why it's thrown under this whole ultrasound umbrella, because we need to know where the placenta and the fetus is. If we do not know where that placenta or that fetus is, we risk doing damage to either of those, or perhaps even both, when we use this long syringe, or this long needle and syringe, to extract that amniotic fluid. If we were to cause the injury to the placenta, we could actually cause it to detach from the wall of the uterus, causing a placental abruption. So we insert this needle, the fluid is aspirated, placed into a centrifuge, and then from here we can do that karyotyping, or that chromosomal analysis. RhoGAM is going to be administered after the amniocentesis if this mother is Rh negative, because there is the potential that we have mixed up, or there's the potential that we mix the fetal blood cells with the maternal blood cells, which would cause the mother to naturally abort the fetus. So obviously we don't want to do that. We're trying to actually be helpful here, not cause a bad situation. So we're going to give that mother the RhoGAM. So one of the things that we can do, like I mentioned, is genetic testing, or karyotyping, which is another way to describe the chromosomal analysis. So during a chromosomal analysis, they place all the chromosomes out and they count to see if any of them are missing, if we have extra, if we have parts of chromosomes, and then from there they look at those in determining if there are any inborn errors, potentially of metabolism or some sort of genetic disorder. Enzymes will also be examined for those inborn errors of metabolism. If we have alpha-fetoprotein levels within that amniotic fluid, then we're concerned for neural tube defects. Alpha-fetoprotein should only be found in the cerebrospinal fluid. So if we have neural tube defects where we have the spine not closing, that neural tube not closing, it's instead leaking CSF out into the amniotic fluid, so we're able to see that that's a problem. So neural tube defects like your spina bifida. Pulmonary maturity is another thing that can be assessed when we're looking at amniotic fluid. Typically that's completed later on in pregnancy because we don't usually too concerned about it earlier on because we're anticipating this delivery to go to term. So the lecithin sphygmal myosin ratio is an indication of surfactant production, which we all know that surfactant is necessary for successful transition for that fetus to that extrauterine life. We're also going to be looking at prostaglandins because we know that those prostaglandins increase the surfactant production. And then the laminar body count, which also contains surfactant. These are particles that are secreted by specialized cells in the alveoli as part of the whole surfactant production process. So amniocentesis is not without risk, though. As I already mentioned, you could have that placental abruption, you could have that fetal injury. That placental abruption, that fetal injury could lead to fetal death. We could end up with a maternal amniotic fluid embolus. We could have an early onset of labor if we irritate that uterus. So we could also cause infection to either the fetus or to the mom. Amniotic fluid leaking or maternal or fetal hemorrhage. Chorionic villi sampling is done earlier than what we would do in amniocentesis. So the chorionic villi are these tiny little fingerprint projections of what will someday become the placenta. This can be done, like I said, earlier on, so it can be completed as early as the first trimester. We're specifically looking for genetic disorders in this case. A genetic disorder that the patient is at risk for, especially if they've had chromosomal analysis prior to that, which would indicate a high risk for a genetic disorder. So again, we're going to use the ultrasound to help determine the location of where that chorionic villi or where that placenta, that immature placenta will be, as well as to locate the fetus. And what we're going to do is we're going to remove a small tissue specimen from the fetal portion of the placenta from the shiny side and from that shiny Schultz side and place it under a microscope. This can be completed transcervically or abdominally, so you can go, as you can see in the top picture, you can go through the cervix and kind of dilate it ever so slightly in order to place that through, or use the needle through the abdomen. Again, we're going to do ROGAM. A choriocentesis or a PUBS is another way to obtain a fetal blood sample and possibly to complete a transfusion in the second and third trimesters. In this case, we're able to see very clearly defined the blood flow through the umbilical artery, or through the umbilical vein, and we access the blood system, the blood circulation in that way. We can go ahead and we can withdraw blood and sample it that way. We do additional testing to make sure that it's fetal blood and not maternal blood that got mixed up. And we're going to monitor that fetal heart rate for an hour or two following the procedure, doing a non-invasive stress test. So basically we have but we've got some test results that are slightly questionable, and we're trying to determine if we're looking at mosaic results where the previous testing was not definitive. Some of the cells are showing abnormal karyotyping versus some of them are normal, etc. These can help us to define exactly what's going on with this fetus. So even though your book talks about these, the amniocentesis, the chorionic villi sampling, and the percutaneous umbilical blood sampling, these are not completed as frequently in modern OBGYN, offices and clinics like they were in the past, because we have more non-invasive, safer techniques to assess fetal well-being. So So we're going to look at maternal serum alpha-fetoprotein. Remember how I was talking about that? You would see that with neural tube defects when the spine has not closed completely, and we have that alpha-fetoprotein circulating within the amniotic fluid. Well, these can also be picked up in maternal serum. Well, heck, if we're concerned about that, let's pick it up in a far less invasive method first, drawing mom's blood. So these are maternal assays. Alright, let's draw mom's blood first and see if we have that circulating before we go on to do an amniocentesis. These can detect, this MSAFP can detect 80 to 85% of all neural tube defects during 14 to 34 weeks of gestation. So obviously it's going to pick up on the majority of them right then without having to go further on. If the MSAFP results are really low, we're going to be concerned about a trisomy disorder. If it's super high, we're going to be concerned about chromosomal disorders. Either way, an abnormality on here, we're going to do some additional testing. This is a test that's now recommended for all pregnant women. The multiple marker screens are the triple and the quad. Again, your book talks about these, but they are really falling out of favor except in the rural clinics, as we have more specific tests now. But again, as your textbook is really talking about these, I will go over them. So the triple and quad, these are used in detection of trisomy disorders. Again, these are maternal assays, so we're pulling from mom's serum. The triple looks at 3 markers, the quad looks at 4. The difference with the 4 is the presence of inhibin A, which some elevated readings could indicate Down syndrome. But the triple screen, we're looking at that MSAFP, unconjugated estrol, and HCG. Coombs testing. So Coombs testing is, you should be hearing about this by now in your nurse-to-nurse report on the postpartum unit. Coombs testing we are concerned about because it's a screening for Rh incompatibilities. So if we have a really elevated result where it's a greater than 1:8 ratio, that can indicate a need for an amniocentesis to look at the severity potentially of hemolytic anemia. If we have a Coombs test that is abnormal as well, we're going to be very concerned for the possibility of like our newborn or neonate with jaundice due to hemolytic anemia. Cell-free DNA testing, so now we're talking about some miscellaneous testing, is a non-invasive prenatal genetic test which is completed between 10 and 20 weeks of gestation. We're looking for fetal Rh status, the fetal gender, certain paternally transmitted single gene disorders. So again, this is typically done if we have a high risk for a chromosomal disorder, for example, a mom greater than 35 years of age. The electronic fetal monitoring is conducted between 32 to 34 weeks to gestation to assess for uteroplacental insufficiency. So this is one of those things that you will need to get pretty familiar with. The non-stress test is one method of doing this. The whole idea here is the uterus, is the placenta going to continue to support the fetus through the rest of the gestation? The non-stress test notes how the fetal heart rate responds to stimuli. So you and I, as we're just sitting here doing this lecture, listening to this lecture, our heart rate's probably fairly low. Now, come exam time, when you are having some stress due to some stimuli, your anxiety is going to go up, that being your stimuli. Your body is stressed, you respond to it, and your heart rate escalates. So, do we want a fetus to respond to stimuli? We absolutely do. When they are under stress, we want that placenta to be able to help that baby react. So, a non-stress test, okay, even though it says non-stress test, we're not basically doing anything to really force that baby, okay, to respond to us. So 1 to 2 times a week, what we'll do is a mom wears a belt, and this is usually done in the clinic. If she feels a fetal movement, she pushes an indicator button, which records it out onto a strip. Interestingly, this on the strip that I observed during an NST, it was a little musical note whenever the mom hit the button. It recorded it. So then we look at the fetal heart rate, and we're going to compare it to the mother's recorded feelings of fetal movement. So let's flip right over here momentarily, and you can see that, okay? So here is any kind of little blip in the contraction of the uterus, and we're going to look up here, and does the fetus respond? Okay, so this one happens to be a non-reactive. This one is reactive. So this is good. This is a good one here, okay? This fetal heart rate is kind of going up and down. The fetus is continuing to respond to the stimuli. Okay, so vibroacoustics, interpretation. So normal findings would be that fetal heart rate increases with contractions or maternal activity. They go down, obviously, when everybody sleeps. Can also decrease with no narcotic use. So if mom does a hit of cocaine before she comes in to complete the non-stress test, we're going to sedate that baby, or she will have sedated that baby, and you're not going to see obviously as much of a reaction. Beta blockers, which also slow heart rates, will also slow the fetal heart rate, and smoking. Contraction stress test or an oxytocin challenge. So if we do a low dose of oxytocin or pitocin, or if we do a nipple stimulation, what we're looking at here is for the possibility of decelerations. So we're trying to replicate what the fetus will experience in labor and how they respond. So again, this baby's not doing too much, and that's concerning. Why isn't this baby moving and grooving? And this baby is moving and grooving. So we've got a spike here, we've got something happening, we've got a few more things happening, and this heart rate comes up very nicely up here to about 180, 185, then drops back down to kind of this basic line here where baby is basically trending out about the 120 range, her fetal heart rate range. We've got a little bit of activity here, and then we have a corresponding spike in the fetal heart rate. All good things. And here are some more. All right. Again, good, bad. This is we've got a ton of activity here, and this fetal heart rate isn't doing too much of anything. Over here we have a little bit of a deceleration, and that would be slightly concerning as well. So perhaps we'll be looking at that. And that concludes the discussion regarding pain management in labor and electronic fetal monitoring.